So should be available in the next few days on our website. So anybody who has missed tonight or couldn't stay for the whole thing or just forgot what the heck we talked about, can watch it again on our website. So with that, let me read a fairly lengthy resume of Dr. Lopez. Very accomplished and very impressive. Dr. Lopez is a licensed psychologist of the state of Florida with a specialty in neuropsychology. She received her PhD from Rosalind Franklin School of Medicine and Science, formerly known as Finch University of Health Sciences, the Chicago Medical School. Following this, she completed a clinical neuropsychology internship and postdoctoral residency at the renowned Shands Teaching Hospital at the University of Florida. Mabel Lopez, PhD, is a neuropsychologist and owner of Mind and Brain Care, LLC, which in 2010 was named Small Business Development Center's Business of the Year. And in 2015, Mind and Brain Care was named Top Female-Owned Business of Southwest Florida by Gulf Coast Magazine. Dr. Lopez has served as the president of the Florida Psychological Association from 2008 to 2012 and board representative from 13 to 15. She was chief of psychiatry and psychology for Lee Memorial Health Systems from 2008 to 2012. And she has been on the Elvin A. Dubin's Alzheimer's Resource Center Advisory Board from 2007 to 13, and Board of Trustees from 13 to present day, where she now serves as part of the Executive Committee. Dr. Lopez has been appointed by the Florida Supreme Court as a lay member of the 20th Circuit's Court's Unlicensed Practice of Law Committee from 2012 to 2017. She has a unique specialization of both pediatric and geriatric neuropsychology, and as a pediatric neuropsychologist, she provides services to children and adolescents with ADHD, learning disabilities, autism spectrum disorders. As a geriatric neuropsychologist, she specializes in different diagnoses of dementias, Alzheimer's, Parkinson's disease, and vascular disease. Dr. Lopez has a background in sports concussion work with the NFL, the NHL, that's CTE, and is currently the sports concussion consultant for Ave Maria University. And her services are available in both English and Spanish. So with that, please give a warm welcome to Dr. Mabel Lopez.
Can you hear me? Yes, no. No. Yes, no. No, yes. Can you hear me now? Better. Okay, I will. Yes? Yes. Got it. Okay. Thank you so much for that introduction, and thank you for having me here. As you can tell, I'm probably a lot older than I look. The first thing I got asked is, how old are you? A lady doesn't tell. So first I'll give you an overview on dementia, because I believe the topic can be very confusing. The word itself is very confusing. As a neuropsychologist, people will come to me with memory problems, but not all memory issues are dementia, and now I'll explain dementia a little better. Basically, we call it the 3 Ds. The person demented, depressed, delirious, or all 3. Those are the top 3 things we find. We find that sometimes a person does have depression that can act as what we call pseudo-dementia. It's a condition that looks like dementia but is not. The person might be delirious. It's a very transient, temporary state of confusion that happens from this metabolic syndromes, maybe a new medication, maybe dehydration. ICU will cause it. Surgery will cause this. Drugs, of course, new medications. Sometimes people are drinking too little or too much, or doing recreational drugs, etc. And then many types of dementia. Do not worry about these acronyms. This stands for Alzheimer's disease plus vascular disease, Lewy bodies, etc. Many combinations that we can have of dementia as well. So as you can tell, my job's very interesting as I try to figure out why a person has a memory issue. And we also have a subset of people I call the worried well. It's okay to forget some things. There's room for that in normal neurotypical behavior. So when I assess the 3Ds, I look for depression, dementia, and delirium, and they all have overlapping symptoms. You could have confusion, apathy, lack of really caring, anhedonia, irritability, poor attention, memory problems, and appetite changes, and you can have that in all three conditions. 20% of people with depression will have a chronic course with no remission. So they'll come to me with a lifelong history of depression, which intermittently looks like dementia. And this is really important because people with depression will eventually have higher risk of developing dementia. Some forms of dementia start with depression 10, 15 years before converting into dementia. So the first symptoms are mood disorder. And so it's really artificial to tear them apart. 80% of people who seek treatment for depression will have relief. So it's not a condition that has no treatment. So I always urge people when they do have depression to seek treatment. I'll talk to you a little bit towards the end about good treatment for depression. And I tend to like things more holistic and naturopathic, more interested in functional medicine. That does not mean that allopathic and medications, that doesn't mean they don't play a role, but whenever possible, keeping it as healthy as possible, as natural as possible. When a person has depression and another medical or neurological condition, there tends to be a synergistic effect, and the person can become more depressed. Obviously, a person with cancer will have a higher incidence rate of depression, but also that depression will make any illness worse. When you do have depression, hospital stays will be twice as long, even if it's the same thing. So two people come in for the flu, the person with depression will stay there twice as long. That's how important mental health is. Often, when a person's depressed, they're more likely to use alcohol, substances, be violent, and have suicidal gestures. So you could turn the hatred inside or the anger inside and want to hurt yourself, or outward and want to hurt others. The biggest risk factors is being a female, being unmarried. Yeah, there's risk factors for everything. Medical illness will increase your risk for having depression. Chronic financial strain, a family history of depression, because we know there's genetic loading, or you've learned some styles of coping, and lack of social support, which unfortunately, as we get older and older, you see more and more of our loved ones. You see my 90-year-olds, my people who are reaching 100, they say, wow, I've lost all my siblings, my spouse. Obviously, mom and dad are gone, so you get lonelier and lonelier, so your risk for depression gets higher and higher. So community like this is so important. I always emphasize community. This is extremely important because depression will look like dementia from time to time. We call that pseudo-dementia, not because the person is faking dementia, but because it really mimics a dementia condition. It's like being in a fog, not thinking clearly, not paying attention. We can distinguish it with our tests, but from day to day, the person functions in a very confused manner. When the depression is gone, the pseudo-dementia clears. So that's the difference. Some dementias, you'll have symptoms of depression preceded. It's very common. It's really important in individuals who have a psychiatric history. Depression, bipolar is a big one too, which is a mood disorder where the person has episodes of depression and mania or hypomania, real high mood. These people are very likely, they're a higher risk for getting dementia. So it's really important that individuals with psychiatric backgrounds get followed and monitored closely. If you have depression and dementia, you have the greatest risk for nursing home placement and death. That's a pretty lethal combination. Delirium, we don't hear about this a lot, but one of the things I see a lot in the hospital is people being misclassified as demented when they're actually delirious. So someone who's perfectly fine one day has a really bad UTI, urinary tract infection, so common. Or right now we're in flu season, January and February we peak at flu. People will become very confused, and if you don't know the background of the person at the hospital, they will misdiagnose you with dementia. In fact, there are units in the hospital that cause dementia. there's something called ICU dementia. I don't know if you've heard of it, but there's so much noise, there's so much light, the person never gets to sleep, there's so much medication and stuff going on that there's a subset of people who become delirious in the ICU. So I'm sorry, it's ICU delirium. There's a whole subset of people that do this. Now, what you see with delirium is that it's acute, whereas something like Alzheimer's is slow progressive. It's not one day yes, one day no. You see an attention distraction, the person gets very disorganized, and it could be just because of surgery, which I want to touch upon because we ignore this for a very long time. Surgical, infection, medications, nutritional deficiencies will cause this. Alcohol and drugs, head trauma. You could get a little delirious from the head, altered mental status after a head injury. Chemo will cause this, and any environmental changes like ICU, which you're not sleeping, there's a lot of lights, a lot of confusion, the person can become delirious. Something I want to touch upon is fairly new in the literature. It's about 14 years old or so. We never recognized, and this sounds insane, that after anesthesia, people become delirious, right? We know this. Have you seen someone waking up from it? Now, you can be delirious, post-operative cognitive delirious, if it lasts for 3 to 4 days. If it lasts more than that 3-day, 72-hour period, then we call it post-operative cognitive dysfunction. And it doesn't matter that the surgery was on your knee. Just general anesthesia can cause this in some people, usually older people. And it does clear. It takes sometimes 3 months, 6 months. I've seen up to 2 years to clear sometimes. But the longer it takes to clear and the more prone you are to it, it's a real high red flag, a risk marker that there's a vulnerable brain involved, and that brain in the future is at high risk for developing dementia. So it's important to recognize that one. Now, the most common question that I get is, what is the difference between dementia and Alzheimer's disease? Dementia is an umbrella term. It just means that there's cognitive changes. There's changes in your thinking. We divide thinking or cognition into what we call domains, cognitive domains. Learning, memory, attention, visual, spatial skills, processing speed are examples of domains. Within domains, we have subdomains. So for memory, visual versus verbal memory, semantic, episodic, declarative, we got a name for everything. But we measure it. And depending on the how far away the person is from the mean, if they're impaired or deficient in a certain category, we know which parts of the brain are not functioning the way they're supposed to, because the brain is kind of really well organized. And we know most of it, but not all of it. But we know that certain diseases attack certain parts of the brain, sometimes asymmetrical, one side, and sometimes bilaterally. So that's how we diagnose it. Not only should, in order to meet criteria for dementia, should 2 cognitive domains be compromised, but they should affect daily living. So some people start having a hard time driving or managing finances or keeping their appointments. And so that's the first sign. But there are many types of dementia. Again, dementia only tells us that there's a thinking problem, but does not tell us the etiology, the root cause of the thinking problem. It's like saying I drive a car, but not what type of car I have. So you could have dementia, but it could be of Alzheimer's, Parkinson's, Huntington's, Lewy bodies, frontotemporal. There's many ways that there's many types of dementia, many root causes. Before you have dementia, you have a prodromal condition that, believe it or not, was identified maybe about 20 years ago or so. Before, we used to think of a person as being normal and then having dementia. And then new research came out and says, no, there's a prodromal, a pre-dementia condition called mild cognitive impairment. The name changed a few years ago to mild neurocognitive disorder. It's the same thing. Scientists thought that name was confusing, so they made a more confusing name. They thought the name dementia was confusing, so they call it a major neurocognitive disorder. So we have normal, this fencing, like you're just sitting in the fence, you may stay there, you might go back to normal, you might get dementia, MCI, and then you have a dementia. Now it gets even more fun for us. We take the memory complaint and cognitive deficits, but it doesn't interfere everyday functioning, and we classify it as a mild cognitive impairment or a mild neurocognitive disorder. And then depending on the type you have, we can sort of guess your risk factors for Alzheimer's and other types of dementia. That's what we do. So if you come to me with the most common type, which is bilateral, amnestic, you have verbal memory and visual memory problems, I know with 80% risk factor, within 5 years, you might develop Alzheimer's type, and so forth. So, now, so major cognitive disorder, dementia, same thing. Illness affects the brain. Many brain cells die. There has to be 2 types of thinking impairment. It gets progressively worse over time in most cases. It will impair everyday activities, and it cannot be secondary to stress. We've all had stressful days where we can't even remember where we put the keys, right? It can be due to mood. It can be like a depression or a pseudo-dementia, and it cannot be a static condition, like for example, someone born with Down syndrome, although they do get Alzheimer's, or someone born with something, cerebral palsy, and they've always had this. A single stroke would not qualify either. There is something called vascular dementia. It's usually more than a single stroke. Any illness to the head is usually ruled out, and head injuries, although if you get a lot of head injuries, you get a type of dementia called chronic traumatic encephalopathy, which is a combination of a lot of dementias. Yeah, now, most of us, when we hear the term dementia, we think of primary neurodegenerative diseases. We think of these diseases that kill our neurons, our brain cells. We think Alzheimer's, Lewy bodies, frontotemporal, Pick's disease. We think of all these. But we forget that you can get dementia from infectious organisms. HIV will give you a subcortical dementia. Herpes will give you a dementia, and herpes type 6 can give you Alzheimer's disease. Lyme disease. Yep. Nutritional metabolic, Wernicke-Korsakoff's is a really fancy way of saying alcohol dementia. It's 1 glass is not going to hurt you. Heavy metal intoxication, of course. Immune inflammation, systemic lupus will lead to dementia. Vascular disease, we talked about all the strokes. Prion diseases, Krusov-Jacobs disease, mad cow disease. You could also get it from your own mitochondria. It doesn't have to be from eating bad meat. So that was my very quick, I usually do a very long lecture on all the dementias. So I didn't go through all of them, but I just want you to get a good understanding of what we're talking about, okay? Because some of these dementias are preventable, okay? We can prevent, obviously, nutritional metabolic issues. We just, don't drink in excess. We can prevent we know we can prevent heart disease. Well, the blood vessels don't stop at the neck. We can prevent heart disease, right? We can prevent strokes. And we know that 80 to 90% is the new number that they're giving of Alzheimer's disease can be prevented, which is pretty cool because there's many pathways to get Alzheimer's, right? There's a genetic pathway that's inevitable. Those people have presenilin 1 or 2 genes. There's a high-risk genetic variant called ApoE4. You're really high risk of getting Alzheimer's, but you may never get it with that gene. Then the rest of us might be getting it from really infection. Yes?
Can you be tested for that gene?
ApoE4, yes. Presenilin 1 and 2, yes. And there's very few families in the world that have presenilin 1 and 2. Your whole family in their 40s and 50s would have had this dementia. Yes, and when Alzheimer's identified the woman, Aloe Alzheimer's, that had Alzheimer's, that's how we got the name Alzheimer's disease, she had presenilin, I want to say 2, but she had one of the dominant genes. So she was a dominant Alzheimer's patient. And so but the most common pathways to get Alzheimer's disease are nutritional. High carbohydrate diets, type 3 diabetes, we call it now, etc. And that's what I'm speaking about. Ways to prevent dementias that are lifestyle related. I am very well aware that there are genetic variants, but most of us, we're going to get Alzheimer's because of the way we eat, from lack of sun exposure, from lack of enough exercise, from pollution, from toxicity. So I want to prevent that. Okay. And obviously some are genetic, like Huntington's. So let's talk about prevention.